Hi, and welcome to another video from the CTAG Clinic. My name is Dr. Mike Lloyd and I'm their Clinic Director. In the video today, we're going to be looking at the process of what's known as overt and covert switching. So these are really aspects of a condition which is known as dissociative identity disorder, also known as DID. And in clinical settings, obviously we see this an awful lot. So some people have sort of covert switching, some people have overt switching, and the switching is the movement or the transition between different parts or aspects of the person's identity, hence the dissociative identity disorder type title of this condition. And what happens is when a person becomes traumatized early in childhood, alters or parts are created in order to try and compartmentalize and protect against the impact of that trauma. And then later in life, often in adulthood, then these parts sort of materialize and come forward and can create enormous amounts of difficulty and distress for the individual. And when there's a lot of parts and the person is quite sort of understanding and aware of all of this, then that person often sort of like refers to themselves or refers to what they carry within them as a system. So that's some of the language that I'm going to be using in this video today. And this feels like a big topic, not necessarily in clinical terms, because in clinical terms we've been working with this for decades. In terms of the sort of the modern world of social media, covert and overt switching have become ever more important and sort of necessary really to define exactly what's going on. And there's a lot of portrayals of what would be the more overt switching on social media. And that, that creates, many issues, so both positive and both negative. The positive is that it sort of enhances the awareness about the condition, DID. And the negative, realistically, is it projects the sort of this image of DID as all being about overt switching of parts, when actually, in terms of everyday life for many people with DID, and certainly in our clinical settings, we don't really see it like that very often. So that overt switching, that kind of the heavily popularized type of overt switching, is not really what we often see, and certainly the manner in which it manifests is not really what we always see in clinical settings. So that creates sort of some difficulties, and we do have many of our patients say that they can't really watch DID on social media because the presentation of the overt switching is very, very different to the experience that they have within themselves for their own DID system. So none of it is particularly right or wrong in any respects. It's just that there is a tendency to portray the overt switching on social media, and actually in real life covert switching is much more common. So like anything else, if there's like a singular type of portrayal, it can lead people to believe that that's what it's all about. And actually within DID, that overt switching is really sort of a minor part of the process. It's heavily significant, but in terms of frequency, it's often not really as portrayed online. In our clinical settings, that sort of friends or people around them, when they know they've got DID, they know they've got parts, is that there's an entertainment value being asked of them. So people will often try and pull out parts, try and make the switching happen because they're entertained by it, or they find it fascinating, or they're super interested. It's like, oh, show me your parts. You've got DID. I want to see what you've got, all these different elements to your being. And a person can really get drawn into a pressurized scenario where there's like a performative function of these parts. And in the old diagnostic criteria of the DSM, in reality, in DSM-4, in order to diagnose DID, the assessing clinician needed to see the parts. And that's changed in the DSM-5. That's no longer the case. And it was felt even from clinical settings that where there is this pressure to try and conform to the expectation of seeing overt switching in order to make the diagnosis, it kind of has a sort of like a very negative attribution to it. And as I said, and the worst excesses of this is that people get sort of drawn into pressure to sort of demonstrate their parts, or the only way I can help you understand my DID is by showing you all of these parts, or whatever it might be like that. So we know that that's not entirely healthy when we think actually that the dissociative parts, whether covert or overt, are all trauma-based. They're coming from a place of great pain, great distress and great suffering, and just kind of like having this showing itself time and time again for any purposes other than sort of clinical purposes to try and move the person and the system towards recovery, or it's kind of like trying to protect against sort of more trauma in the present day. It might not be all that helpful. We know that for both covert and overt switching, it can be a controlled process, and certainly within the stabilization, what we would look for is the type of switching that happens is understood, controlled, and ideally not just in response to an environmental trigger. So the overt switching is quite obvious. That's that sort of very visible, very observable switching between different aspects of a person's or system's identity. And the covert switching is often where it's much more hidden, it's much more sort of subtle often, and it's much harder to observe. So a person or a system with a lot of covert switching can often find getting a diagnosis of DID very difficult because it doesn't have that kind of great big sort of dramatic, visible aspect to it. It often means that people get misdiagnosed. If they're able to describe the internal workings of the system well enough, that's not so bad, because then we can end up with a condition such as other specified dissociative disorder, also known as OSDD. And what can often happen is people get diagnosed with OSDD because the switching is very covert, i.e. not visible, not really observable, not really coming out on a regular or easily seen basis. But when a person then goes into therapy and that therapeutic relationship starts building, the internal system starts becoming much more visible within the therapeutic arena, if you like, and then the clinician, the therapist working with that person, working with that system, may decide to kind of change the diagnosis from OSDD to DID as these parts and the switching become more observable, and therefore the awareness of what nature of the condition is starts changing over time. And good therapists should never want to try and get all the parts out. It's just allowing the system to manifest itself in whatever feels comfortable or right at any one time. So some of the things that are similar between covert and overt DID is that it's often very distressing, and it can often cause a lot of grief, it can often cause a lot of shame, and it can cause a lot of embarrassment. And obviously if we think of it in terms of like a sliding scale, the more overt the switching is, the more obvious and sort of like, big the switching is, the greater the likelihood of it causing difficulties and problems for that individual. Now, they may or may not be aware of it. Amnesia might be present, amnesia might not be present. Levels of distress can be present for absolutely both, but there tends to be a kind of a greater kind of dramatic effect for the overt switching. So people end up having to sort of like pull back, make excuses, and really try and repair any damage that might have been caused as a result of that switch. With covert switching, people are better really at kind of making excuses. So there may be a switch and it might get seen, or something might just get noticed. And often people are very adept at kind of making excuses, coming up with reasons why that might have happened, deflecting, avoiding, moving away from the sort of the gaze of the other person, questioning and trying to get sort of an answer as to what may have happened. So with the covert switching, people become very good at really kind of making it seem as if the switch that happened did not happen. That's if they're aware of it at all. A lot of people with covert DID are not particularly aware that the switch can happen. So that subtlety might not be observed on the outside, and it might not be understood or seen or recognized on the inside. So that means that these switches could be happening a lot in lots of different places, and no one's really aware of it. And the only way really of being able to understand at times that covert switch has happened is with this sort of a vague sense of unease, if you like, an echo, that once that part has arrived and as that part has left, they can leave sort of traces of their being behind to be picked up and understood. And that can be quite a distressing or difficult sort of experience to have that, especially if there's amnesia. And if we remember again that a lot of these parts are about the trauma. So some of them may hold traumatic memories, some of them may hold a lot of very intense negative emotions. So when they emerge and when they leave, it can leave an echo of those very unpleasant and difficult emotions behind. And if a person isn't aware that switch has happened, they may not even be aware that they've got DID, for example, then what they're left with is this kind of like very weird sensation that's seemingly come out of absolutely nowhere. So what we often try and work with within stabilization is a sort of a controlled way of being able to manage this. And in that stabilization process, the degree to which covert or overt switching is happening is trying to be sort of managed, controlled, and made into a collaborative process. So while we're not saying we need to see all the switching happen, what we also are saying is we need to understand why the switching has happened and see whether or not we can move to a scenario where only switching happens when it's kind of like accepted or agreed that should happen. So it's less about it happening in response to an environmental trigger, i.e. a traumatic switch, and much more about a controlled, purposeful, useful switch, with the goal being communication between all parts. And the better the communication within the system, the better the likelihood of recovery from the condition such as DID is ever going to be. And sometimes the overt switching, the really obvious, powerful switching, is the stuff that makes it a lot harder to develop the communications, because it has so much more power, has so much more punch to it in a way, that it's really difficult to try and hold it all together and make sense of it. And it's a lot easier for people just want to deny it, push it away and say, I just want to get rid of everything that is causing me grief and distress. In the overt switching, sometimes the communication is actually a lot easier to understand. Because the nature of it being covert in the first place, it feels like there's more of a controlled method as to why the switch actually takes place. So if we think about it on the inside, it's like, let's say, springs in a box. The overt switching are very powerful springs that kind of push the alter, push the part out. It's quite a forceful sort of like introject. With the covert switching, the springs are a lot less kind of managed. So it's like, do we need to do it? Do we not need to do it? Let's peep out, let's have a look, let's come back. So the nature of the force can often feel very difficult. And this is why a lot of people don't really recognize or experience that the covert switch takes place, because it has less of a sort of like a movement through the membrane, if you like, from the internal world to the outside world. Whereas with the overt switching, it's much more like a punch that comes through that membrane. So obviously it leaves behind more traces and can actually leave people with a lot of sort of physical difficulties. They may get headaches, they may get pains, they may find discomfort because of the power and the force it's taken for that alter to switch through. Largely though, when we look at some of those differences, that energy, that power, if you like, for the really obvious switching is simply recognized by people in the outside world. So they're much more likely to question it, much more likely to challenge and try and make sense of it, point it out as much more frequently. With the covert switching, people are generally not doing that, and clinicians may also not be aware. So when we do our training courses and we really kind of help people understand, help clinicians understand what to look for, especially with covert switching, they often then go back into their memory banks of other patients that they've seen over the years and think, I think that's what was going on. I probably just didn't recognize it. I didn't know what I was seeing, because there are specific things that we would be looking for. And a clinician that's skilled, trained and experienced in the awareness of switching, the awareness of the dissociative systems, we can spot some of this stuff quite easily and we can make sense of it, and then that builds into the therapeutic piece of work. Clinicians that are not that trained in this can get really lost and just not really understand what's going on. So the awareness of it, the training of it and the experience of it really become extremely important, sort of like, techniques and skills that a therapist should have. So I hope, I suppose in conclusion really, that it doesn't really matter whether it's covert or overt DID in terms of the diagnostic system, especially nowadays in the sort of the way we approach it now. We don't need to see the switching take place at all. The overt switching, the obvious switching, is simply a lot easier to diagnose, and the covert switching makes it a little bit more complicated, a little bit more tricky, but actually it doesn't really make that much of a difference. The impact on the outside world of the overt switching can be more dramatic, and it can create a lot of problems that the covert switching doesn't really do. The covert switching is much more about hidden, it's much more about keeping things secret, and denial and amnesia and lack of awareness are all sort of built into that. The really obvious sort of overt switching just has a sort of different impact on the outside world. And that's the stuff that tends to sort of get filmed and put down and shown on camera and doing all those kind of things, because it's like, look at my DID. And actually, it's really not all about that. That's just one aspect of DID that is actually relevant in terms of the diagnostic categories that we work with. But that's the stuff that kind of has that more sort of visible, dramatic effect in the online sort of social media type stuff. So, there are benefits to having overt switching, there are benefits to having covert switching, and there are negatives. So what we have to work with ultimately is underlying regardless of whether it's overt, whether it's covert, is to understand the nature of the trauma system lying underneath any switching that takes place. So from a clinical perspective, we don't really mind whether it's overt or covert switching at all, as long as there's an understanding being developed as to why any switching takes place, and we get into that sort of cause and effect model. So our focus isn't on the nature of the switching in the clinical space. It should not be that the case. I mean, I've worked with people where I may have spent 2 to 3 years working with them. I've rarely ever seen any switching whatsoever. It makes no difference from a clinical perspective. The difference seems to be much more out there in the world in terms of, you know, what's going on for that person and you know, the groups that they're working with or being around socially or whatever it might be. So the impact is much more outside the clinical room than inside the clinical room. So when we think about covert and overt switching, it's a question that I get asked a lot. And I kind of shrug my shoulders and go, I don't really mind. It doesn't really make any difference to me as a therapist, whether it's one or the other. But helping the person come to terms with the diagnosis, that's where it really makes a difference, because it's easier to deny covert switching and it's kind of almost impossible to deny overt switching. So there we have it. I hope that that's kind of given a bit of an overview on the nature and the approach that we take when we're looking at these things, just to sort of develop an understanding as whether overt or covert switching is better or worse than the other, or whether it makes no difference whatsoever. But actually the things that need to be done with it, regardless, are really where the importance sits. So thanks ever so much for watching this video. I really look forward to leaving your comments and thoughts afterwards. It'd be much appreciated just to see what people think about this video, and always do the like, subscribing and do the notifications so that you're aware when we're dropping new videos. And we've got a lot more to be working with, both in this, you know, in this sort of like discussion point about the type of switching that takes place, and in lots and lots of other things. So please do keep an eye on the channel for lots more videos. And in between now and the next one, as always, please do take great care.